everybody. It's Dr. Becker. We are going to get into Chapter 4, Pharmacokinetics, Pharmacodynamics, and Drug Interactions. I'm going to jump over to osmosis videos by Elsevier. You guys probably recognize this as these were similar to the videos that you saw maybe in your in your pathophysiology course you've already taken. This is on their website for the Elsevier YouTube videos. I do not own the right to these. I've recorded them just so that I can loop them in here so that it's all in one spot. So here we go. Hold on.
Or chemical compounds which interact with various living systems, from tiny molecules, heart failure, and depression.
All right, just a second. Sorry, getting this
Chemical
figured out.
compounds which interact with various living systems, from tiny molecules to cells to tissues and whole organisms, in order to produce a certain effect. Every day, more and more new medications are designed to fight diseases, from infections to cancer, heart failure, and depression. But the process of developing a new medication can take a lot of time and money, and it typically consists of 3 steps. Step 1 is discovery, and that's when a candidate compound is picked out as a possible therapeutic agent for a specific disease. Step 2 is preclinical research, during which this compound is tested on cell cultures and animals, like mice and rats, mainly to see if it causes any serious harm on living organisms. And finally, Step 3 is clinical development, during which clinical trials are performed. That's where the compound is tested on humans to see if it's safe and effective in treating diseases. For a new medication, clinical trials are done in 4 phases, which can be remembered with the mnemonic, all medications need the seal of approval, which stands for safety, efficacy, approval, and long-term. Phase 1 trials test the medication in a small group of healthy individuals to see if it's safe for humans. Phase 2 trials.
I'm pausing that here. This is for review. I am not going to ask you any questions on your exam about the phase of clinical trials.
Trials aim to find out more about how effective the medication is or how well it works at a certain dose. This is done by testing it on a moderately sized group of individuals affected by the condition in question. In Phase 3 trials, the new medication is compared to the standard treatment to find out if it's actually just as good as or even better than the existing one. Phase 3 trials generally involve a much larger number of individuals and aim to replicate the exact setting in which the medication will be administered in real life, which will then be used as the basis for approval by regulatory organizations for the market. The whole process can take up to 10 years or more, depending on the compound. But if all this goes well, congratulations, we've got a new medication. Now, that new medication will have at least 3 names. A chemical one, describing its chemical structure and used mostly in scientific studies, like N-acetyl-P-aminophenol. A generic name, which is usually a shortened version of the chemical name and is mostly used by health professionals, such as paracetamol or acetaminophen. And 1 or more brand or trade names, given by the pharmaceutical companies that make the medication, such as Panadol or Tylenol. Okay. But the journey of drug development hasn't finished quite yet. Once a medication reaches the marketplace, there's Phase 4, which is a final phase of safety surveillance that looks for long-term or rare side effects that might have been missed. If it's found to be unsafe, a recall and ban might be needed. Alright, now once a medication is administered, it starts interacting with the body. This interaction can be broken down into pharmacokinetics and pharmacodynamics. Pharmacokinetics refers to the movement and modification of the medication inside the body. In other words, it's what the body does to this medication. So, once the medication gets administered, it first has to be absorbed into the circulation, then distributed to various tissues throughout the body, metabolized or broken down, and finally eliminated or excreted in the urine or feces.
So this is what we refer to as pharmacokinetics, the ADME. That's an acronym you'll also often see. So pharmacokinetics, the movement and modification of your medication in your body, ADME, absorbed, distributed, metabolized, eliminated, or excreted.
You can remember this as ADME, absorption, distribution, metabolism, and excretion. Pharmacodynamics, on the other hand, refers to what the medication does to the body. So, once again, after the administration of a medication, it binds to receptors or specialized proteins located on the surface of or inside a cell. This gives rise to a signal cascade, which ultimately results in some change in the cell's function, like boosting the production of a particular type of protein or slowing down DNA replication. An ideal medication would produce a single beneficial or therapeutic effect for a certain disease state. In reality, though, most medications produce several unwanted effects, called side effects, like nausea or fatigue. Now, in order to determine the safety of a medication, we can look at its therapeutic index. The therapeutic index refers to the ratio between the toxic dose and effective dose of a given medication. We can illustrate this using a nice graph that shows the relationship between the amount of a medication given, also known as dose on the x-axis, usually on a logarithmic scale, with the response produced on the y-axis. What we get is an S-shaped curve called dose-response curve. So, to calculate the therapeutic index, we divide the median toxic dose, or TD50, which is the dose that causes a toxic response in 50% of the population, by the median effective dose, or ED50, which is the dose that produces a clinically desired effect in 50% of the population. The closer the ratio is to 1, the higher the danger of toxicity, so the larger the therapeutic index, the safer a medication is considered to be. Alright. Medications that have a low therapeutic index have a narrow margin of safety, which means that there is a thin line between the dose needed to produce the desired effect and the toxic dose. So these medications, including warfarin, lithium, digoxin, gentamicin, phenytoin, or theophylline, require close monitoring of serum levels.
And those are probably honestly the top 6. When you think about narrow therapeutic index, narrow therapeutic window, these are the ones to think of. It's worth reiterating those in your mind and chewing on them. Warfarin, lithium, digoxin, gentamicin, phenytoin, and theophylline. Those are the top ones. Those are drug levels that you would be checking, especially in acute care. If you have patients that are on these medications, it's something that should immediately pique your interest.
Finally, let's talk about what happens when 2 or more medications are administered together. First of all, there are a whole bunch of ways medications can interact with each other, both at pharmacokinetic and pharmacodynamic levels. Pharmacokinetic interactions occur when one medication alters the absorption, distribution, metabolism, or excretion of another, thereby changing the amount of medication available to produce the desired effect. For example, in pharmacokinetics, it might be that 2 medications are metabolized by the same enzymes, so they compete for the same enzyme sites. On the other hand, pharmacodynamic interactions occur when medications influence each other's effects directly. For example, 2 medications might both increase the blood pressure, producing a synergistic effect where the blood pressure goes up even higher than what you'd expect by simply adding the 2 medication effects together. Likewise, a medication might work to increase blood pressure by simply opposing the effect of another medication, thereby having an antagonistic effect. Alright, as a quick recap, each medication is developed in 3 steps: a discovery, preclinical, and clinical step, and has 3 names: a chemical, generic, and brand name. Pharmacokinetics studies what the body does to a medication, and pharmacodynamics studies what a medication does to the body, including its beneficial and side effects. Medications with a narrow therapeutic index need to be closely monitored to prevent toxicity. Drug interactions may occur on both pharmacokinetic and pharmacodynamic levels.
So one more time to let that sink in, pharmacokinetics is the study of the drug as it moves throughout the body. Pharmacokinetics can also include drug metabolism and drug excretion. Passage of the drugs across the membranes. And remember, ADME, absorption, distribution, metabolism, excretion. Right, here's their next video from Osmosis from Elsevier. This is found on YouTube. I've recorded it. I'm going to play it here so that you guys can have this all in one place. Here we go.
Pharmacokinetics refers to the movement and modification of a medication inside the body. In other words, it's what the body does to a medication and how it does it. Okay, first things first. A medication needs a way to be administered or a route of administration. Depending on the form of the chemical preparation, like a pill, solution, spray, or ointment, and the part of the body being treated, the medication can be administered through various means or routes, such as swallowed by the mouth or orally, injected into a vein or intravenously, injected into a muscle or intramuscularly, inhaled into the lungs, sprayed into the nose or nasally, and applied onto the skin or cutaneously. Once a medication is administered, it first has to be absorbed into the circulation, then distributed throughout the body, metabolized or broken down, and finally excreted in the urine or feces. This process can be broken down into 4 components with the acronym ADME, which stands for absorption, distribution, metabolism, and excretion. Now, the loss of drug through chemical metabolism, which makes it inactive, and through physical excretion out of the body, can together be referred to as elimination. Okay, so let's start with absorption. Absorption is the process of moving the medication from the site of administration into the circulation. With the exception of intravenous administration, a medication will need to cross one or more cell membranes before it reaches the circulation. Movement across the cell membrane can occur via passive transport, which requires no energy, and active transport, which requires energy in the form of adenosine triphosphate, or ATP. 2 types of passive transport are used: facilitated diffusion and passive diffusion. Facilitated diffusion helps larger, water-soluble, and polar medications move across the membrane through transport proteins like channels and carrier proteins. Passive diffusion helps small, lipid-soluble, and nonpolar medications move across the membrane from an area of high concentration to low concentration. But sometimes active transport is needed, meaning that the medication is transported against their concentration gradient. This involves specific carrier proteins that use ATP as a fuel to pump medications into the cell. Now, sometimes medication molecules are so large that the cell resorts to bulk transport, also known as endocytosis, where the cell membrane invaginates and swallows up the medication, forming vesicles. Now, the rate of the absorption, or how quickly this process occurs, as well as the extent of the absorption, or how much of that medication reaches the bloodstream, depend on several factors. One of them is the pH of the environment where absorption takes place. Okay, so most medications are either weak acids or weak bases, and can exist in an uncharged or charged form. The uncharged form is the lipid-soluble, nonpolar one, which happily diffuses through the cell membrane, while the charged form is water-soluble and polar, and thus cannot diffuse through the cell membrane easily. The ratio between the 2 forms is determined by the pH of the environment and the strength of the weak acid or base. The strength is measured by pKa, which is the pH value when concentrations of the uncharged and charged forms equal each other. So, when the charged form of a weak acid, A-, shows up in an acidic environment with a lower pH and plenty of hydrogen H+ ions around, it will grab one of them and turn into its uncharged form, HA. HA can then be readily absorbed across the cell membrane. On the flip side, if the charged form of a weak base, BH+, is placed into an alkaline environment with a higher pH and a lack of hydrogen H+ ions, it's going to give up its own hydrogen H+ ion and become an uncharged B. It can then pass through the cell membrane just like HA. So in other words, weakly acidic medications will be better absorbed in an acidic environment, like the proximal duodenum, in contrast to weakly basic medications, which are more likely to get absorbed in an alkaline environment, like the distal ileum of the small intestine. Note that even though the stomach is acidic, it's not suitable for the absorption of even weak acids, mainly because of its thick mucus layer.
Pausing that right there, please take note of this. These 3 concepts right here. And the stomach is acidic but it's not always suitable for absorption because of its increased in thick mucus production.
Okay, now another factor influencing absorption is the surface area available. A good place for absorption is the small intestine. With its circular folds, villi, and microvilli, the total surface is actually about 250 square meters, the size of a tennis court. Other factors also include the blood supply to the absorption site and the presence of food or other material in the gastrointestinal tract that can either promote or inhibit absorption. So, after a medication is taken by mouth, it gets absorbed through the walls of the small intestine and transported into the liver via the portal vein. Once in the liver, hepatic enzymes work on the medication to metabolize it. This process is known as first-pass metabolism or first-pass effect and is responsible for breaking down most medications into their inactive metabolites, as well as converting certain prodrugs into their active metabolites before entering the general circulation. This, however, means that if a medication is taken orally and it undergoes extensive first-pass metabolism, their concentration in the bloodstream can get so reduced that once they reach their site of action, they can't produce the desired effect. In that case, alternative routes of administration should be considered, including intravenous, intramuscular, transdermal, sublingual, or inhalational administration. What these do is bypass the first pass effect, allowing medications to go straight into the systemic circulation and produce their effect. Okay, so this brings us to the concept of bioavailability. Bioavailability, or F, is actually the fraction of an administered medication that eventually reaches the circulation in the unchanged form. For example, if someone takes 100 milligrams of pantoprazole orally and only 77 milligrams of this is absorbed into the circulation, the bioavailability is 0.77 or 77%. In contrast, if the same 100 milligrams pantoprazole is taken intravenously, all of it goes directly into the circulation, bypassing the gastrointestinal absorption and first-pass metabolism. So medications administered intravenously will always have a bioavailability of 1 or 100%. Let's plot all this into a nice graph to show the relationship between time on the x-axis and the plasma concentration of the medication on the y-axis after both oral and intravenous administration. Thus, bioavailability of an oral medication can be estimated by dividing the area under curve, or AUC for short, of the oral form by the AUC of the intravenous form. And both AUCs need to be corrected by the dose of medication, or D for short, administered orally and intravenously. So the bioavailability F of a medication is AUC oral times D intravenous over AUC intravenous times D oral.
I'm not going to ask you how to calculate anything like this. I'm not going to give you any area under the curve and you have to figure out with math. But it's good to understand how they come to these numbers and what the numbers mean. But you're not going to have to do that on a test or a quiz.
All right, so once the absorption has been completed, we are ready for the distribution of the medication. Distribution is the movement of a medication from the circulation into the body tissues. Once again, the rate and extent of distribution depends on several factors. So one of them is blood supply to different tissues. Medications will be more rapidly distributed to body tissues that receive large amounts of blood supply, like the brain, liver, and kidneys, and less to the tissues with poor blood supply, like the skin and adipose tissue.
What's actually causing you to have blurry vision?
It has to go through the so-called blood-brain barrier, which is strictly regulated. Think of the blood-brain barrier as the brain's bouncer, a highly selective membrane that turns away large, water-soluble medications that are floating around in the blood, while letting in smaller, fat-soluble medications. Similarly, the size and polarity of a medication affects its distribution. So in general, smaller, hydrophobic or lipid-soluble medications can easily cross through the lipid bilayer cell membranes, giving them an extra edge in distribution over large, hydrophilic or water-soluble medications. Another factor affecting distribution is the degree of plasma protein binding. Medications travel through the bloodstream partly bound to plasma proteins like albumin and partly unbound or free. But only the unbound fraction is free to diffuse into tissues, whereas medication molecules that are bound to plasma proteins remain limited to the plasma, acting as a kind of reservoir. That's why medications with lower plasma protein binding, such as gentamicin, get distributed readily in the tissues, while medications with higher plasma protein binding, such as warfarin, take much more time to free themselves and diffuse, thus giving them a longer duration of action. Finally, an important concept is the apparent volume of distribution, or VD, of a medication, which is used to represent how extensively a medication is distributed throughout the body. It is the hypothetical volume that accommodates all of the medication in the body if the concentration throughout was the same as in plasma. Let's simplify this with an example. Let's say we inject 100 milligrams of a medication into the blood and none of it is excreted. Then an hour later we find the plasma concentration is 50 milligrams per liter. To calculate the apparent volume of distribution, we need to divide the dose administered intravenously, in milligrams, by the plasma concentration of the medication, in milligrams per liter. So we get 100 milligrams over 50 milligrams per liter to get a VD of 2 liters. The thing here is that we assume that the medication is distributed evenly throughout the body, although that's not the case for most medications. So, smaller, lipid-soluble medications can cross cell membranes easily, so they get distributed in extravascular body tissues, organs, and fat cells, while medications that are larger and water-soluble stay mostly in the plasma. In any case, it's safe to say that medications with a rather small apparent volume of distribution, or VD, such as 3 liters or less, remain mainly in the plasma. Medications with an apparent volume of distribution, or VD, of 16 liters or more get distributed throughout the extracellular fluid, meaning both the plasma and interstitial fluid compartments. And medications with an apparent volume of distribution, or VD, of 46 liters or more are possibly distributed throughout all body compartments. Now, there are certain situations where this apparent volume of distribution may get altered. For example, in chronic liver diseases like cirrhosis where the liver is unable to produce enough plasma protein, or in certain kidney conditions like CKD or chronic kidney disease where excess amounts of plasma proteins get filtered out through urine, the amount of plasma protein-bound medication gets reduced substantially, therefore increasing the VD.
Pausing that here, please take a moment and make sure this is in your notes somewhere. This is written down, that these are something that you're hearing and learning and remembering. Your volume of distribution is likely going to be altered with significant liver disease such as cirrhosis because you're unable to produce enough plasma protein, or with chronic kidney disease because you have too much plasma proteins getting filtered out. So pause that here, take a second, pause this lecture if you need to, get this slide written down.
All right. As a quick recap, absorption refers to the movement of medication from the site of administration into the circulation. It can occur through passive diffusion, facilitated diffusion, active transport, and endocytosis, and is determined by the route of administration, the pH of the environment, the chemical properties of the medication, the surface area and blood supply of the absorptive surface, the amount of contact time with the absorptive surface, and the presence of food or other medications in the gastrointestinal tract. Bioavailability is a measure of the absorption, and distribution is the movement of a medication from the circulation into the body's tissues, which depends on blood flow to tissues, size and polarity, and plasma protein binding. The apparent volume of distribution, or VD, is a measure of the extent of distribution, and it can be affected by certain kidney and liver conditions.
Helping current and future clinicians focus, learn, retain, and thrive. Learn more.
All right, I hope you found those 2 videos helpful. You can go back and look for them on your own if you Google Pharmacokinetics by Osmosis by Elsevier if you want to listen to them separately at a different time. I think that's a really nice review for those of us that are audio learners to hear that again as concepts, so that as we're talking throughout the course and we talk about volume of distribution or things like that come up, you understand what they're referring to. It's a good review. The different routes of administration, again, it's nice because sometimes we choose non-oral routes because the patient's unconscious or can't take an oral medication, but also it's nice because we essentially eliminate the first pass effect. And so we have a lot of quote unquote tricks up our sleeves of how we can achieve different things. So there's maybe a purpose of why you would give somebody who could take the oral medication. Perhaps you want to give them an IV version of it for a specific reason. But just because their gut works and they're awake and conscious and they could take the pill, maybe for their specific situation, we're choosing an alternate route because we're bypassing, because we want better bypassing first pass effect, or we want better bioavailability for whatever reason. This here again is the review of the pharmacodynamics. This slide I think is really helpful because it helps explain agonists, antagonists, partial antagonists. If this is something that you get confused on, like to me, I swear these words sound so similarly, and I always have to stop and think for a second, what do they mean? What am I trying to say? Write these out, read up on them, think on them, make sure you feel comfortable with what they mean so that as we review them throughout the semester when we're talking about different drugs, you feel comfortable with what they are. Agonists are molecules that activate the receptors. Antagonists produce their effects by preventing the receptor activation by endogenous regulatory molecules and drugs. And partial agonists are agonists that only have moderate intrinsic activity. Jumping over to the textbook, Laney's textbook, we're in chapter 4 still. This is figure 4.1. I like this as a visualization as well of what we're talking about. The absorption can happen here with the GI tract typically, or remember we have all those other administration sites. At the end of the day, they're making their way into our bloodstream then to be distributed, okay? They typically go then to the liver, the kidneys, their direct site of action, or other sites. And in those spots, then this is where our metabolism happens. And then they're excreted typically through the bile or through the urine. Table 4.1 in your book, remember some of these concepts to review, have them fresh in your mind. IV is instantaneous. There's many advantages. It does have a disadvantage. It's irreversible. Once you push that drug, it's not coming back out, right? It's inconvenient because you need an IV. There's risks associated with it, fluid overload, infection, possible embolism. And then the drug has to be water soluble. Intramuscular, we've got barriers, could be capillary wall. The absorption pattern is rapid. Positives, it permits the use of poorly soluble drugs, permits the use of depot preparations. We talk about that, a lot of that in birth control and in psychiatric drugs. Discomfort, obviously, is a potential bad part of it, and it can be inconvenient. Subcutaneous, the same as IM. The enteral route, okay, barriers could be the epithelial lining of the GI tract or the capillary wall. It can have a very slow and variable onset, but it's easy, it's convenient, it's typically the most common form of drug, so they tend to be inexpensive. We can give them to ourselves, and there's the potential for a reversal. But again, their variability is there. They can interact with other drugs, can cause nausea or vomiting from local annotation, and the patient has to be conscious and cooperative. There is one area that the video did not necessarily address, and that is placental drug transfer. As we care for adults, women that could be carrying a fetus, they could have the potential for placental drug transfer. So we're highlighting that here. The membranes of the placenta separate your maternal circulation from your fetal circulation. However, the membrane of the placenta do not constitute an absolute barrier to the passage of drugs. That's why we always pay attention to, is the drug safe to take in pregnancy? The same factors that determine the movement of drugs across one membrane, other membranes determine the movement of drugs across the placenta. Most drugs will cross the placenta via simple diffusion. Lipid-soluble, non-ionized compounds readily pass from your maternal bloodstream into the blood of the fetus. But in contrast, compounds that are ionized, highly polar, or protein-bound are largely excluded. So that is an illustration of that. So again, the takeaway here is you have to pay attention to pregnancy as a consideration because you could have an unwanted bad effect on the placenta, of the fetus through the placenta transfer. That was an unintended consequence. Next concept here, again, we're still in chapter 4. When we talk about drugs that bind to proteins, right? So we said if you have liver disease such as cirrhosis, if you have kidney disease, those are two common conditions that you tend to not have the proper proteins. And we think about that. We know that if you don't have the right serum albumin, that can affect things. But remember, a point to remember here, even though a drug can bind albumin, there's only some molecules will be bound at any moment. The percentage of drug molecules that are bound is determined by the strength of the attraction between albumin and the drug. The example they give here in your text is warfarin. So the binding between albumin and warfarin is incredibly strong, so that nearly all of your warfarin, over 99%, is bound to plasma. Only 1% is free. But on the other hand, your attraction between gentamicin and albumin is very weak. Less than 10% of the gentamicin molecules will be bound in plasma, and 90% are free. So the important consequence of this is that it affects drug distribution. Because albumin is too large to leave the bloodstream, drug molecules that are bound to albumin cannot leave either. So as a result, bound molecules cannot reach their sites of action and therefore cannot undergo metabolism or excretion until the drug-protein bond is broken so that the drug is free to leave circulation. So in addition to restricting drug distribution, protein binding can be a source of drug interactions. Each molecule of albumin has only a few sites that a drug can connect. Because the number of binding sites is limited, drugs with the ability to bind albumin will compete with one another for those sites. So if I'm giving gentamicin and warfarin, if warfarin's binding and their affinity for each other is much stronger, warfarin's going to get bound ahead of gentamicin because their binding is weak. So that is why some drugs can have interactions, right? So let's say you have warfarin on board. So they're highly affinity, they have a high affinity for that binding. And then you give another drug that also has a high affinity for plasma. If they start competing and you start having a lot more free warfarin, that affects your INR. And that's why those drugs can be dangerous together. Because how warfarin was working in your body before you added that drug is now different because you've added that drug and they are competing for binding space on the albumin. Next point to bring up as a highlight from your reading, metabolism. Most drug metabolism takes place in the liver. So obviously if you have cirrhosis or liver cancer or things where the liver is not functioning correctly, this could change our metabolism of the drug. The P450 system is the hepatic microsomal enzyme system, okay? And that's a key component. So it's important to appreciate that the cytochrome P450 is not a single molecular entity, but a group of closely related enzymes. And they break the CP450 down into CYP1, 2, and 3. And then we have other ones The other 9 families metabolize endogenous compounds. Okay, not to get into the weeds. I don't expect you to memorize C1, 2, or 3, but to understand this as a concept is that hepatic drug metabolism is a very important concept to understand when you're understanding the therapeutics of the drug. Okay, drug metabolism has 6 possible consequences of therapeutic significance. Okay, so your metabolism, how fast you metabolize or how slow you metabolize the drug, has these 6 possible consequences. 1, accelerated renal excretion of drugs. 2, drug inactivation. 3, increased therapeutic action. 4, activation of prodrugs. 5, increased toxicity. Or 6, decreased toxicity. Okay. The most important consequence of drug metabolism is promotion of renal drug excretion. The kidneys, which are the major organs of drug excretion, are unable to excrete drugs that are highly lipid soluble. So, by converting lipid soluble drugs to more hydrophilic or water soluble forms, metabolic conversion can accelerate renal excretions of many agents. Drug metabolism can convert pharmacologically active compounds to inactive compounds. Metabolism can increase the effectiveness of some drugs. For example, metabolism converts codeine into morphine. The analgesic activity of morphine is so much greater than that of codeine that formation of morphine may account for virtually all the pain relief that occurs after codeine administration. The activation of a prodrug. So the prodrug is a compound that is pharmacologically inactive as administered and then undergoes conversion to its active form through metabolism. So your body is going to change that drug and activate it with its metabolism process. So prodrugs have several advantages. For example, a drug that cannot cross the blood-brain barrier may be able to do so as a lipid-soluble prodrug that is then converted to the active drug in the CNS. So by changing the compound of the drug, we can maybe sneak into the CNS system in the way that the drug is formulated as a prodrug that will be activated through the metabolism process. But by converting drugs into inactive forms, metabolism can decrease toxicity. So metabolism can also increase the potential for harm by converting relatively safe compounds into forms that are toxic. Really what we're saying here is that the drug that goes in, the drug that's circulated, and the drug that comes out, it can undergo and transform and change quite a bit through metabolism. And that can be a good thing, or that can be a bad thing. When we talk about metabolites, those are those byproducts or what happens after metabolism. And some of those are bad, obviously. So if you have something going on in your body that affects your metabolism, we have these 6 things that could happen, and some of them could be very dangerous, right? So that's why we talk about age. We're not talking so much about infancy at all, because we're talking about adults here. But as we age and our liver and our kidneys grow older and also age, geriatric and elderly excretion is different than that of a 20-year-old. If we have drugs that may inhibit the P450 or interact with the P450 way, we're going to alter the metabolism of the drug, and so we can have interactions there because of metabolism. Drugs that increase the rate of drug metabolism are inducers. Okay? Drugs that decrease the rate of the drug metabolism are called inhibitors. Often a drug may have more than one property. You could be both an inducer and an inhibitor. Inducers act on the liver to stimulate enzyme synthesis. So this is called induction. To me, inducers and induction, I think of turning on and activating in a good way. If dose adjustments are not made to accommodate for this, a drug may not achieve therapeutic levels. Inhibitors act on the liver through a process known as inhibition. So by slowing the rate of metabolism, inhibition can cause an increase in the active drug accumulation. So again, this is kind of the bully standing and slowing people down and not letting anything be as efficient. And that allows the drug to accumulate, which can be good. Sometimes we purposely give inhibitors, but it has the potential to be very bad because if you turn inhibition on and you start to accumulate, that can often lead then to a toxicity. I do want to go into excretion in some more detail, and we're back still in chapter 4. Excretion is anything that removes the drug from the body. Again, far and away, the majority of excretion happens in the liver and the kidneys, but you have to remember things like breast milk, sweat, saliva, even expired air that we breathe out. Renal drug excretion, again, we talk about the kidneys. When they're healthy, they serve to limit the duration of action of many drugs. But then when you have unhealthy kidneys and renal failure or chronic kidney is occurring, both the duration and the intensity of drug responses may increase. Oftentimes you'll see if they have kidney disease, right? You don't give the drug as often because it tends to stay around in the system longer. They are slower to excrete the drug. So let's review this again. We're going back to our pathophysiology days. Urinary excretion is the net result of 3 processes. So you have to have your glomerular filtration, your passive tubal reabsorption, and then your active tubal secretion. Okay, so when we talk about the glomerular filtration, that's our GFR. As the blood flows through the glomerular capillaries, fluids and small molecules, including the drugs, are forced through the pores of the capillary wall, called glomerular filtration. And this moves the drug from the blood into the tubular urine. Remember, blood cells and proteins are too big to pass through the capillary pores, so they do not undergo filtration. Because large molecules are not filtered, drugs bound to albumin will remain in the blood. Passive tubular reabsorption. The vessels that deliver the blood into the glomerulus return to the proximity within the renal tubule at the point distal to the glomerulus. This is getting very technical. What we're trying to say here is that drugs that are lipid soluble undergo passive reabsorption from the tubule back into the blood. So if you have drugs that are not lipid soluble, they will remain in the urine to be excreted. And you can see that here. We have our blood meeting into the glomerular filtration. So low molecular weight drugs that are not protein bound, will pass through here and now they become part of urine, okay? But if you're protein bound, you can't pass through. You're going to come down through the blood supply again into here, which is your passive reabsorption. Lipid soluble drugs may come back out into here, but non-lipid soluble drugs bounce back and they stay within the urine. And then we also have another site here, which is our active transport. The tubular pumps for organic acid and bases move drugs from blood back into the urine. So these are kind of the 3 different steps. Once these drugs get down here and they're non-lipid soluble drugs, they're going to stay in the urine. And this is what essentially makes our urine and how things are excreted through the urine. This active transport, active tubular secretion here, these pumps have a relatively high capacity and play a significant role in excreting our drugs. Okay. All right. Instead of reinventing the wheel, I'm going to YouTube. This is Ninja Nerds. This guy is pretty darn phenomenal in his explanation and his ability to draw on the whiteboard. This video is about 22 minutes long. We're going to listen to it here. If you guys don't want to listen to this, fast forward to 22 minutes, but I think it's a darn fine review of pharmacokinetics, specifically drug excretion. Here we go. This is off of YouTube. I do not have the rights to this video.
We're talking about getting rid of the drug, so it's excreting the drug out of the body. And there's obviously a lot of different organs that can excrete drugs out of the body, right? So it's whatever organs are open to the atmosphere. So the kidneys can actually be the primary way that we excrete drugs. So when we talk about excretion, getting rid of a drug or eliminating it from the body, the primary way would be excretion via the kidneys. So we would urinate out the drug. The second one is we could take a drug, and that sometimes, drugs are actually absorbed across the GI tract. They get into the bile system. They will be actually conjugated with certain types of biomolecules and then excreted out via the enterohepatic circulation. So sometimes we can actually excrete substances out via the bile. We can also exhale, so anesthetics. So whenever people are taking certain types of inhaled gases like anesthetics, these can actually be exhaled. So the lungs can also exhale specific types of inhaled gases and excrete them out of the body in that particular way. And the last one is you could have a drug that you actually take and none of it gets absorbed across the GI tract. It exerts its effects within the GI tract, but none of it gets absorbed. And so because of that, you actually eliminate maybe all of the drug or a portion of the drug out via the feces. So we can actually eliminate drugs via the GI tract by, again, not absorbing the drug and then excreting out part of the drug, or exhaling out particular types of inhaled gases, or excreting into the biliary system, which does end up into the feces because it gets absorbed across the GI tract, gets taken into the enterohepatic circulation, and then excreted into the biliary system, or we can excrete the drug into the urine. This is going to be the most common and the most important one. And whenever we're talking about excreting particular drugs, it obviously, since the kidneys are the primary mechanism, kidney function is extremely critical and crucial to the ability to excrete particular drugs from the body. If a patient has chronic kidney disease, acute kidney injury, just complete destroyed up kidneys, are they going to be able to excrete most of the drugs into the urine? No, and so the drugs can accumulate. So it's important to be able to remember that. So what are the different factors that are affecting excretion by the kidney, since the kidneys are the primary one? We're going to talk about filtration, secretion, reabsorption, and then we'll talk about how we can modify particular excretion of drugs. Pretty cool concept here, something called ion trapping. All right, so for filtration, with basic concept, when we actually have a drug that's moving through the actual kidneys, it'll move through the afferent arteriole. When it moves through the afferent arteriole, it'll get to the glomerulus. And then from the glomerulus, via what's called the glomerular hydrostatic pressure, we can filter particular drugs across the glomerulus into the actual Bowman's capsule. So this is your Bowman's capsule, and then it'll go into what's called the proximal convoluted tubule. But this process by which hydrostatic pressure pushes certain types of things out of the plasma into the Bowman's capsule, this is called filtration. And filtration is primarily dependent upon something called glomerular filtration rate. So for example,
You do not need to know Bowman's capsule. I will not test over that particular, but we want to understand the concept of the GFR.
If a patient has some type of chronic kidney disease, acute kidney injury for whatever particular reason, and they have a decreased glomerular filtration rate, what happens to the amount of drug that's filtered across the glomerulus? Well, if there's a reduction in GFR, that means that there's less plasma, less volume of plasma that's actually excreted from or moved out of the plasma into the Bowman's capsule. That means that potentially less drug is also going to be moved from the blood into the actual Bowman's capsule, into the actual tubular system. If that's the case, that means that we have less filtered drug and potentially higher blood drug concentration. So that's an important concept to remember, that as patients develop something like chronic kidney disease, or they develop a very severe acute kidney injury, their ability to filter particular things decreases, such as drugs. If there's a decreased filtration, there is an increase in the actual serum concentration of that drug and more toxic side effects. So important to remember that you actually should adjust particular doses of a drug in situations like CKD and acute kidney injury. The next thing that we also have to talk about here is that not only is filtration dependent upon the GFR, it's also dependent upon the proteins, such as albumin.
Yes.
You know, albumin is an important protein that helps to be able to bind to a particular drug. So for example, if we wanted the drug to be able to move out into the Bowman's capsule, right, we know that in order for this process to take place, the drug has to be able to not be heavily protein bound. So if you have a drug that's like super, super protein bound, what do you think the chances that you're going to be able to filter that drug across? Not very good. So whenever you have situations where there's actually lots of albumin, lots of protein binding, that'll actually decrease the filtration of the drug and keep it inside of the blood. So increase protein binding of drug will do what? It'll actually have less drug filtered across the glomerulus and into the actual Bowman's capsule, effectively increasing the serum or blood concentration of the drug, increasing the potential like toxicity or side effects of that. So that's an important thing to remember. Whenever drugs are protein bound, there's going to be less excretion of the drug and less elimination of the drug out of the body. So it's an important thing to be able to remember. So again, filtration is heavily dependent. I'd say this is the more important one, GFR. GFR, the glomerular filtration rate, the volume that we're actually filtering across the actual glomerulus every minute. If that decreases, that means that we're not going to filter as much plasma across, meaning that we're not going to filter as much drug that's in that plasma across. Not as much is going to go into the urine, more of it's going to be retained with inside of the blood. So that's an important thing to remember. But if you have a normal GFR, good kidneys, and a decent protein binding, but not heavily protein bound things, what's going to happen? You're going to have good amounts of drugs that will be filtered across. And the same concept, if you have decreased protein binding, what's going to happen? Decreased protein binding, that drug will be able to easily move across or filter across the actual glomerulus and into the actual Bowman's capsule. So less protein binding in situations like what? Maybe if a patient has what's called cirrhosis and they have less albumin, what happens? They excrete a lot of the drug, and maybe that can actually decrease the efficacy of the drug. Or in patients who have chronic kidney disease and they lose lots of albumin in their urine, they have less albumin in the blood to be able to bind onto the drug, and lots of drug can actually be eliminated from the body. So again, important to remember these concepts. All right, secretion. This is another important concept here. So let's say that you have a drug, right, comes in via the afferent arteriole, moves into the glomerulus. Some of the drug is actually filtered across the glomerulus. So some of the drug actually crosses over the glomerulus and into the Bowman's capsule, right, via the filtration process. But not all of it does. And some of the drug actually remains in the efferent arteriole. And then from there, you know the efferent arterioles move into something called the peritubular capillaries. And then some of those can actually go down into the medulla of the kidney and actually cause what's called the vasa recta. But let's say that some of these actual drugs remain in the peritubular capillary blood. Not all of it gets filtered. So this was step one, filtration. Not all of it gets filtered. Some of it makes it to the peritubular capillary blood. When it gets there, guess what's really cool here? You have the opportunity to move this drug from the peritubular capillary blood across the kidney tubular cells and into the actual lumen of the kidney tubules.
Again, general concept here. We know that filtration is a way that we can excrete, and now we're just talking the general concept here. We don't have to know all of these technical terms. I just want you to recognize there's these three mechanisms that we can excrete drugs.
So that it can be easily excreted. In order to do that, it depends upon the actual solubility of the drug and the concentration gradient of the drug. So let's say, for example, I have one drug.
Again, general idea.
And this drug, so drug 1 for excretion, and then drug 2 for excretion. Drug 1 is polar. It is water soluble. Polar.
I jumped forward a little bit here.
It's lipophilic, or let's actually put this as hydrophobic, so it can interact
a little bit here.
So for example, if I had a drug that I wanted to secrete, and I had another drug that I was taking, for example, one of them that's a big one is like cimetidine. If I was taking cimetidine, or if I was taking like another drug, so other ones that can actually do this, trimethoprim sulfamethoxazole, which is an antibiotic, these can directly interact with these transporters. And if they inhibit these transporters, they won't be able to secrete this drug via these transport processes into the tubular lumen, and so they'll build up inside of the blood.
Remember, we talked about that just briefly, that the inhibitors, they're like big bullies standing in the way, saying, no, we're not going to let you through. I'm going to kind of turn this system off, make it not work as well. Now, you can't have that drug through this secretion process get back into there to be excreted into the urine. So an inhibitor interaction could be a bad thing at this junction.
So remember that. This process of secretion is highly dependent upon the transporters and ATP. And if you have other drugs which can interact or inhibit these transporters, can you secrete the drugs out? No. So it's really important to remember that this step of excretion can be affected by not just the solubility of the drug, concentration gradient of the drug, but by drug interactions working against these transporters. Don't forget that. All right. The third step that we need to talk about that affects excretion is reabsorption. Let's come down and talk about that now. All right, so when we talk about reabsorption, this is basically the drug getting back into the circulation. The whole point was to excrete the drug, right? So we could filter the drug across, right? That was the filtration process, highly dependent upon the GFR. Low GFR means low filtration of the drug, less of it's going to be cleared from the body. The other way was that we talked about some of the drug can actually be excreted from the proximal convoluted tubular blood into the actual kidney tubular lumen. This is highly dependent upon the solubility of the drug, the weight of the drug, the charge of the drug, the concentration gradient, but it also depends upon the transporters. If those transporters are inhibited, they won't be able to excrete the drugs that need to be moved against their concentration gradient, that are large, that are charged, and that are water soluble, okay? The last thing is, let's say that some of these drugs are filtered, some of them are secreted, they move through the proximal convoluted tubule down the descending loop of Henle, through the ascending loop of Henle, and then it gets to the distal convoluted tubule. When you get to the distal convoluted tubule, there should be a decent chunk of drugs that are present in this area. So the concentration of the drug via the filtration and the secretion process should increase the concentration of the drug here. And theoretically, the concentration of the drug should be pretty low here in the actual peritubular capillary blood, or the vasa recta blood. So because of that, that's a good concentration gradient for drugs to be able to move from areas of high to low. But what kind of drug would move down its concentration gradient easily without any kind of transporter? A small, nonpolar, and hydrophobic drug. So drugs that are nonpolar, that are small, so low molecular weight, and hydrophobic, so very lipid soluble, won't require any type of transport proteins, won't require any kind of active transport process at all, and they can easily passively diffuse across this into the actual bloodstream. And then the point of this was to excrete the drug. That's a problematic issue. So now this drug is not going to be excreted as much as I want it to be excreted. The whole thing that I can do with this is I can send this to who? What can I do? After this, I can send this drug to the liver. And what the liver can do is it can actually go through what's called phase 1, maybe add on an OH group. Then it can maybe go through phase 2, add on some type of like conjugate, like glucuronate, make it more polar. And if it's a more polar molecule, if it's definitely more water soluble, will it be able to be reabsorbed whenever it gets to that point again? No. It'll be way more difficult to absorb. So again, it's important to remember that in this situation, these drugs will be reabsorbed, which will decrease the excretion of the drug. So what will happen is whenever they get back into the blood, they'll go to the liver, they'll be metabolized further, and then hopefully become a little bit more polar, hydrophilic, charged, and more difficult for them to be reabsorbed. So they can effectively excrete the drug from the body. I hope that makes sense. Now, here's something that's really, really cool, and it's very important in situations like overdose and preventing reabsorption. So you see how that reabsorption process is highly dependent upon the characteristics of the drug. So if it's very nonpolar, very small, very hydrophobic, it's going to easily be reabsorbed. There's another factor that also affects this. And this is basically the charge, right? So the charge, so we said nonpolar, which is basically that's not charged. Small, hydrophobic. If I have a drug, let's say I have an overdose, I take a patient who takes too much phenobarbital, or I have a patient who takes too much aspirin. These drugs are weak acids. Do you guys remember that equation? So we said let's actually do this according to the color. So we'll put NP, and this one is polar. This is the one that would not get easily absorbed. If I took a drug like phenobarbital and aspirin, I took way too much of it, and I don't want to keep reabsorbing the dang thing. I want to excrete it into the urine and make sure that I don't reabsorb the dang thing anymore. I'd want it to be in this form, because in this form where it's charged, it's polar, it's not going to absorb easily across this. It's going to need a transport protein of some kind. So if I have a patient who took an overdose and they have too much of this and I don't want them to reabsorb it anymore, I want them to excrete it into the urine. What could I do that would increase the actual process, that would shift this reaction, I did it in purple there, that would shift this reaction to the right? If I wanted to shift this reaction to the right to make more of this, because if I make more of this molecule, it will not be reabsorbed, and effectively, it'll be excreted. Okay? In other words, we'll trap it in the urine so that it can be excreted, and I don't bring it into the blood. What would I need to do? Well, I would need to do what to the proton? I need to decrease the concentration on that right side of the reaction. So if I decrease the amount of protons, what does that mean? I need to alkalinize the urine. So if I make the urine alkaline, that's going to do what to the actual protons? That's going to decrease the protons. If I decrease the protons, that'll shift the reaction towards the right, meaning I'll make more of this guy and it won't get reabsorbed because it's polar, and I'll excrete it and trap it into the urine, getting rid of it. How in the heck would I alkalinize the urine? What do we give to these patients to alkalinize, trap the phenobarbital and aspirin into this form and get them excreted from the urine? We give them something called bicarbonate, sodium bicarbonate, because it'll alkalinize the urine, drop the amount of protons, shift the reaction to the right, make more of this guy, and then you won't be able to reabsorb him, and effectively excrete him into the urine. Take the opposite situation. You have a patient who takes amphetamines, and they just take a little bit too much for some particular reason. So they have an amphetamine overdose. This is a weak base. If they take a weak base, I did that one in blue. If they take a weak base, you guys remember that this was BH positive, dissociates into B and protons. Which one of these? The B is the nonpolar one. So will that be easily absorbed? Yeah, I don't want it to be that one then. This is the polar one. Will this be easily absorbed? No. So I want this to be converted into this type of molecule, because if I do this one, if I have more of this BH positive, this thing is not going to be absorbed. It'll be effectively excreted or trapped into the urine. So I need it to be in this form. The only way I can get more of it going into this side is if I either do what? Increase the concentration on the right side of the reaction, because I can't decrease this, it's already there. I can increase the concentration of some of the molecules on the right side of the reaction.
All right, I'm going to
So in
pause
order
this
to
here
do that,
and kind of move forward from that. This is him speaking
what's up,
about it
engineers?
at the
In this video
beginning.
today, we're going to be talking about pharmacokinetics. Also, to
This is
really
an option
enhance
for
your
you
learning
guys if
experience,
you
I
need
promise
more
you go through
time
with
to
me.
chew on
In
this
this
and to learn
particular
it.
way, you're going to understand it, you're going to remember, and you're going to do well in those exams. Go down the description box below. We have a link to our website. On our website, we have all the diagrams that we're going to talk about. Where it's empty, you guys can follow along with me filling in the blanks. Okay, please do that. Also, if you want to, you have a completely filled off illustration and also some really comprehensive notes to follow along with me. So let's get started talking about pharmacokinetics.
So I say that because that is something that you guys have at your disposal on your own time as well. Jumping back now. Back to chapter 4, another concept to make sure you guys caught in your reading was relative potency. The term potency refers to the amount of drug we must give to elicit an effect. Potency is indicated by the relative position of the dose-response curve along the x-axis. Potency is rarely an important characteristic of a drug. We use it all the time in clinical practice, like, oh, that drug is really potent, but we're not really meaning what it actually means. The only consequence of having greater potency in a drug is that you can give it in smaller doses. It doesn't mean it's a better drug or a different drug. It just simply means it packs a good punch in a small dose. Whereas if you need the same punch, you maybe need a larger dose of it, but both drugs at that punch are equal, if that makes sense. So the potency of a drug is relative. It's a term we throw around quite a bit, but it actually really just means how much of the drug is needed to take to get that punch. But when you compare punch for punch or efficacy to efficacy between two drugs, if they both equal or work just the same, and then the potency doesn't necessarily matter, if that makes sense. It's important to remember that the potency of a drug implies nothing about its maximal efficacy. So I just wanted to point that out here. Here, the binding of a drug to its receptor is usually reversible. So receptors are activated by interactions with other molecules. So under physiologic conditions, endogenous compounds, so our neurotransmitters, our hormones, or our other regulatory molecules, those are the molecules that bind to receptors to produce a response. When a drug is the molecule that binds to a receptor, all that it can do is mimic or block the action of the endogenous regulatory molecule. So think about that a second. If I give a drug and it binds to that receptor, all that drug is doing is mimicking or blocking the action of the endogenous regulatory molecule, depending on how it works. So by doing that, the drug will either increase or decrease the rate of the normal physiologic activity that was normally controlled by that receptor. So because drug action is limited to mimicking or blocking the body's own regulatory molecules, the drugs do not actually give the cells new function. So in other words, drugs cannot make the body do anything that it is not already capable of doing. Right? When we're talking about drug receptors, okay? So here's an example. Interaction of drugs with receptors for norepinephrine. Under physiologic conditions, cardiac output can be increased by binding of norepinephrine receptors of the heart. So norepinephrine is supplied to these receptors by nerves. These same receptors can be acted on by drugs, which can either mimic the action of endogenous norepinephrine, and thereby they will increase the cardiac output. So they're going to increase and add to norepinephrine activity, or they block the action of your endogenous norepinephrine and they reduce your cardiac output. So normally, if my body is going to have the norepinephrine from here, it's going to click in and lock in here. And when it does that, it's going to increase my cardiac output. My drug that I give somebody, if it comes in here and it blocks this and cuts this off, so now this norepinephrine here can't get there, the effect cannot occur. If I block the action, because I block this from binding, thereby I'm reducing the effect, I'm reducing the cardiac output. But if I give a drug that mimics, when it binds, it acts like norepinephrine, I can still get the desired effect, which is my increased cardiac output. So when we talk about selectivity, what are we saying? We're saying that the ability of that drug to elicit only the response for which the drug is given is highly desirable. So if I want to give a drug that blocks this, and that's all that drug does, is it blocks this from this happening, and it has no other effects anywhere else in the body, that's a fantastic drug. I can give one drug and it's going to do one thing. That hardly ever happens, right? We're targeting that. The more selective a drug is, meaning it only acts in the heart. So if we say a drug is cardioselective, that's great, because very few places outside of the heart does that drug work on, which is excellent. That's a great drug. When we have a drug that's non-selective, that means, yes, it will work in the heart where I want it to, but it also causes problems in the GI tract, the respiratory tract, and the kidneys, which are not what I want. So selective drugs are good drugs that we're striving for. In modern medicine, we're constantly striving to have more selective drugs. Selective drug action is possible because drugs act through specific receptors. We have receptors for each of our neurotransmitters, receptors for each of our hormones, and receptors for all of the other molecules that the body uses to regulate our normal physiologic processes. Think of histamines, prostaglandins, leukotrienes. So, as a general rule, each type of receptor participates in the regulation of just a few processes. So if a drug interacts with only one type of receptor, and if that receptor just regulates a few processes, then the effects of the drug is limited in a good way to just the thing we're trying to achieve. But conversely, if a drug interacts with several different receptor types, then the drug is going to give us a wide variety of effects and therefore likely give us wide side effects. Like this in your book, this example with the lock and the key. In some ways, a receptor is analogous to a lock, and a drug is analogous to the key for that lock. The two theories that we function on in pharmacology today is the simple occupancy theory and the modified occupancy theory. The simple occupancy theory states that the intensity of the response of the drug is proportional to the number of receptors occupied by that drug. And a maximal response will occur when all available receptors have been occupied, as in here. The trouble is that this theory cannot explain how one drug can have higher maximal efficacy than others. So the modified occupancy theory says that we have affinity and intrinsic activity. So we've learned more along the way. And I want to take the time to go through this because this does come back up throughout the rest of the chapters. Affinity, please write this down and get this in your brain, fresh in your head, pull it out from your cobwebs from the back of our mind when we first learned about this, maybe for some of you decades ago. Affinity refers to the strength of the attraction between a drug and its receptor. Intrinsic activity refers to the ability of a drug to activate the receptor after binding. So we go through this because affinity and intrinsic activity are independent properties of each other. So if our affinity is the strength of the attraction between the drugs and its receptors, drugs with high affinity are strongly attracted to the receptors. This is in the concept of a magnet. It's a really strong magnet. The minute they get close and close and close, and then they snap together, right? That snap together, that's high affinity. They're so attracted to each other that the minute they get even near each other, they zing together and they find each other. Okay, high affinity, very strongly attracted. But with weak affinity, they have to be almost already touching before they realize, oh, we can go together, and they just mildly come together. Okay, very different. Because high affinity drugs are strongly attracted to their receptors, drugs with high affinity can bind to their receptors when present in low concentrations. Okay? Because they bind to receptors at low concentrations, drugs with high affinity are effective in low doses. That is, drugs with high affinity are very potent. Okay, so maybe I only have to give 3 milligrams of that drug, and they're so strongly attracted, all 3 milligrams are boom, they're going to find their target and they're going to come together. So drugs with high affinity are very potent. They're very strongly attracted. They bind very quickly. They find each other through all sorts of traffic. They're so strongly attracted that they're going to find each other and they're going to bind firmly, snugly, and securely. Low affinity drugs have a harder time maybe finding each other. Their pull towards each other, their magnetism is maybe not the same. Intrinsic activity means once the drug binds, okay, so once they come together and they're touching, how strongly that drug works on that receptor is its intrinsic activity. So if it has high intrinsic activity, they will have high effect. Okay. Causing intense receptor activation, they cause intense responses. Okay. So think of it this way. If my drug that I give has high affinity, so it very quickly finds each other and they lock together very tightly, and it gives a 10,000 volt to start that process and just turns it on, and super powerful turn on, it has both high affinity and high intrinsic activity. So affinity means they can come together and they find each other very strongly and they bind very closely. And once they're bound together, the high intrinsic activity means it works really well and it's super efficacious. It turns it on very strongly, activates it strongly. That's high affinity. We want that's high intrinsic activity. We want high affinity and we want high intrinsic activity. So the idea here is this. Under the modified theory, two drugs can occupy the same number of receptors, but produce effects of different intensity. So if I give a drug A, and it's a high affinity, high intrinsic activity, and I give drug B, which is high affinity, but low intrinsic activity, both of those drugs may occupy the same receptors. They may bound the protein very strongly to each other, or the receptor very strongly to be bound at the site. But the difference is the intrinsic activity. Both of them could find their targets very quickly and they could seal together very well. But if drug A turns on and activates much stronger than drug B, drug A has a higher intrinsic activity, and that is why it's more efficacious and it works better. I hope that concept makes sense. Please reach out to me if it doesn't, and I'm happy to talk about it with you in more detail. Being said, again, agonists are molecules that activate my receptor. Okay, so I think of an agonist as the good guy. So they are doing what was meant to be done. So if you have a receptor, and if you have a lock, when you put the key in, the purpose is it activates, it turns it, and it opens the door, and the physiologic function that it was meant to do happens. So the key fits nicely, the lock turns, and we start that process well. It's doing what it's supposed to be doing. It's the good guy doing the good thing. It's an agonist. Because neurotransmitters and hormones and all the other endogenous regulators activate the receptors to which they bind, they're considered agonists. So in other words, they bind, so they see the lock, the agonist is the key, the agonist comes in, it fits perfectly into that lock, and it can turn it on the way it's supposed to do. That's your agonist. So when a drug is an agonist, they bind, they find each other, they bind and mimic the action of the body's own regulatory processes. For example, dobutamine is a drug that mimics the action of norepinephrine at receptors on the heart. So if I give dobutamine and it is an agonist, so it binds to that spot and turns it on like it would norepinephrine, and I get increased heart rate and contractility. It's an agonist. It's working in the way that it's supposed to do. So an agonist, in theory, then, is a drug has both affinity and high intrinsic activity. I hope this is all coming together. So if I have a lock sitting on the outside of a cell, okay, and I give the drug. So with that drug, I give a bunch of floating keys. The key is able to find the right lock. That's affinity. It very quickly goes, ooh, that's my lock, I got you, and very quickly lands there. With the affinity, the key gets inserted into the lock. So now we have high affinity, and it turns on the right way and activates strongly the right way what the body was already processed to do or set up to do. That is a drug. That's an agonist because it has high affinity and high intrinsic activity. An antagonist, okay, produce their effects by preventing receptor activation by our own endogenous molecules. Okay, so an antagonist means on the top of my cell, I have a lock and I give a drug. But the drug is no longer a key, an antagonist. So now this drug is a big wad of chewing gum. Okay, and now it finds its way to that lock and it jams inside the lock hole, the keyhole, and blocks it completely. So the next natural process, the natural key that's going to come up and wants to insert into that lock, it can't. It is blocked by the drug, by the big wad of chewing gum I've shoved in that lock. So the chewing gum drugs are the antagonists. By giving that drug, I am now preventing the body from carrying out a normal physiologic function. So an antagonist is a drug with affinity for a receptor, but it has no intrinsic activity, right? So I give that drug, so I give a bunch of circulating chunks of bubble gum. It has high affinity. It's going to find the right lock, but it's not a key. It's a wad of gum. And when they slap together and they meet, that gum goes right into the keyhole and blocks it off. It doesn't turn anything on. It just inactivates that lock from being turned by the right key. So that's my antagonist. Okay. So even though the antagonist does not activate that receptor, right? It has no intrinsic activity. They most certainly do produce a pharmacologic effect because each key of our normal body's making, so all of our endogenous keys that we make on our own, they can no longer go into that keyhole. So by preventing the activation of that receptor, we are producing an effect. So this is what happens with antihistamines. So antihistamine are histamine receptors, antagonists. So they suppress allergy symptoms by binding to the receptors for histamine. So if you have a histamine receptor, that's a lock with a keyhole in it, and I give an antihistamine. That's that big wad of chewing gum. It circulates. It has high affinity. It's going to find that histamine lock quickly, and it's going to plug it with bubble gum. So now my body can no longer use that lock and turn the key the right way to activate my allergies. So I have produced an effect because I'm not allowing the body to carry out its normal physiologic function. It's important to note that the response to an antagonist is determined by how much agonist is present. So because antagonists prevent activation, if there's no agonist present, administration of the antagonist will not work then. You're not going to get any effect. So if you don't have seasonal allergies and you give an antihistamine, you're not going to have a noticeable change, is what they're saying for that example. But on the other hand, if receptors are undergoing activation by the agonists, the administration of an antagonist will shut the process down, right? So if I'm having seasonal allergies, I have a bunch of keys floating around that are activating my histamine. They're fitting into place. They're turning on. This is all normal physiologic function as a response to my environment. And now I give an antihistamine. Now I'm going to see an effect. My allergies stop. Okay. So antagonists can be divided into two major classes. We have our non-competitive antagonists and our competitive antagonists. Most of them are competitive. Let's talk about what that means. Non-competitive antagonists bind irreversibly to the receptors. So irreversibly, meaning not only does the gum go in the lock, but it hardens, it calcifies, and it's not going to reverse. It's never coming back out. A competitive one means that they bind reversibly. So the gum's going to go in there, but it's only going to last about, let's say, 8 hours, and then it's going to fade and crumple and go away, and the keyhole opens back up. So competitive agonists is a weird thought to me. To me, it should be the other way around. But competitive agonists only last for a shorter amount of time, so they're reversible. Eventually, that blockage of the lock goes away, and the lock is open again to be used and activated. So in the presence of sufficiently high amounts of agonists, agonist molecules will occupy all receptors and inhibition will be completely overcome, which is seen here. I wouldn't get too tucked along into those details, but the idea is most of the agonists, or excuse me, the antagonists that we give are chewing gum that dissolve over time and they eventually fade away. Very few drugs that are antagonists harden into cement and completely irreversibly forever for the life of that receptor, for the life of the lock, irreversibly harden it. I'm going to pause the lecture here now as we've gotten to almost 90 minutes, and then look for me in part 2.